The following podcast is part of a certified educational activity titled Preparing for Personalized Care in Myelodysplastic Syndromes, Integrating Innovative Treatments into a Cohesive Patient Care Model. Access the entire activity and complete the post-test at peerview.com/ZAW860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Good morning. This is Dr. Stephen Gore, and on behalf of PeerView Live, I'm very pleased to welcome you to this ASH Friday Satellite Symposium entitled Preparing for Personalized Care in Myelodysplastic Syndromes, Integrating Innovative Treatments into a Cohesive Patient Care Model. I'm from the National Cancer Institute actually in Shady Grove, Rockville, Maryland. Today, I'm very fortunate to be joined by my colleagues, Dr. Prapti Patel from the Harold Simmons Comprehensive Cancer Center in Dallas, Dr. David Salman from the Moffitt Cancer Center in Tampa, and Mike Savona from Vanderbilt University in Music City, Nashville, Tennessee. Alrighty, without further ado then, this is our agenda. We have 3 sections, and each section will have some didactic content, followed by a case presentation and discussion, and followed by Q&A from our audience. And as you can see, the first topic is who is at risk, looking at prognostic scoring systems and risk stratification in myelodysplastic syndromes. The second section will be around treatment strategies and clinical decision-making in MDS, discussing approved therapies. And the third section will be on evolving standards of care, including novel combinations and emerging therapies. So without further ado, I'd like to introduce our first speaker, Dr. Prapti Patel. Again, she's an associate professor of medicine in heme malignancies and stem cell transplant at the Harold Simmons Comprehensive Cancer Center in Dallas, Texas. Prapti, take it away.
Thank you, Steve. Thank you for your kind introduction. And thank you to MLI and PVI for the kind invitation to speak about defining the modern role in prognostic scoring systems and risk stratification in MDS. So this is the obligatory introduction slide to MDS. Most of us in this group already know that MDS is a heterogeneous clonal hematopoietic stem cell neoplasm, and it's characterized by cytopenias, dysplasia with possible presence of blasts, sometimes ineffective hematopoiesis, recurrent cytogenetic and molecular abnormalities, and a bulk of my talk will be focused on this portion, and also an increased tendency towards AML. The overall incidence for MDS is about 5 per 100,000, making it the most common myeloid neoplasm. However, in cancer registries, MDS is widely underrepresented. So there are some estimates that predict 75 per 100,000 in the 60 years and above age group. So currently there's about 10,000 cases a year of MDS, and the median age is over 60 years old. You can see here, according to the Ipssr database, that the age of, or the incidence of MDS rises with age, making the median age of diagnosis about the 7th or 8th decade in life. There are quite a few risk factors for MDS, but a majority of them occur de novo with no identifiable cause. However, there are some loose correlations with cigarette smoking, ionizing radiation, organic chemicals, herbicides, and pesticides that have been looked at in the past. There's also secondary MDS that's with chemotherapy, especially with alkylating agents. The presentation is usually linked to cytopenias, fatigue, and lab abnormalities include macrocytosis and any low blood cell line. There's rarely signs of hemolysis due to ineffective erythropoiesis. So there's quite a bit of challenge that comes with diagnosing MDS. The first one I would think is to rule out other causes that mimic MDS, both pathologically with dysplasia in the bone marrow and also clinically with causing cytopenias. But once we move past that, the big task becomes placing the patient in a bucket, whether it's low grade or high grade or in transformation to AML. And that's where a lot of these clinical criteria and cytogenetic and molecular abnormalities help us place these patients onto the spectrum of MDS. So when looking at the diagnostic criteria and the differential diagnosis of MDS, of course, we're looking for cytopenias as described over here, and also the WHO criteria to diagnose MDS with dysplasia, presence of blasts, and some type of clonal abnormality. In addition, we would want to exclude any other causes of cytopenias, which include vitamin B12 or folate deficiency, any kind of viral infection. And I'd like to call special attention to copper deficiency, which can mimic MDS under the microscope. Also, medications and alcohol abuse can cause a clinical picture of MDS. So when looking at the 2016 WHO classification, there's a few bullet points that are used to diagnose MDS. Of course, we want to see dysplasia in greater than 10% of any of the cell lines. There can be blasts that are present, but oftentimes, as seen in low-risk MDS, there's 0 to 5% blasts. We can often see cytogenetic abnormalities, and that's seen about half of the time in MDS patients. But one of the things I'd like to call special attention to is certain cytogenetic abnormalities that cannot be used to make the diagnosis of myelodysplastic syndrome, and that includes trisomy 8, deletion Y, and deletion 20q, since these abnormalities can be seen in other heme diagnoses such as aplastic anemia and bone marrow failure syndromes. Flow cytometry cannot be used to diagnose MDS. However, there are certain characteristics that can be seen in the immunophenotype, such as loss of CD56. One of the most important things that this talk will focus on is Mds type mutations that are seen in the molecular signature on the bone marrow. So kind of moving into the meat of this talk, I'm going to talk about the prognostic implications of these somatic mutations that we found. And really, this is what ties into the risk of MDS, because the risk is built on what the overall outlook will be and the overall risk of transforming to AML. Knowing this risk provides prognostic information for our patients, and it also helps us as treating physicians determine how aggressive the therapy needs to be. So if it's a low-risk MDS, not to use a therapy that has so many side effects that ruins the quality of life of the patient, but doesn't really alter the eventual path of the disease, as we see in low-risk MDS. Or do we need to treat with a therapy that will alter the path of the disease, as we see in high-risk MDS? So in order to grasp where the patient falls on this spectrum, we really need to consider a complete cytogenetic evaluation along with a next-generation sequencing panel to help us prognosticate where the patient sits. So traditionally, in the WHO criteria, we look at genetic abnormalities. And most often, I'd like to call your attention to the right side of the slide, are these copy number changes. So we can see deletion of chromosome material, which is historically associated with poorer risk MDS, or addition of chromosome material, such as trisomy 8. Again, remember that trisomy 8, deletion Y, and deletion 20q are not pathognomonic for MDS. Now, with the advent of next-generation sequencing, we can also find point mutations in genetic material by doing the genotype sequencing. And unlike cytogenetic abnormalities, which is present in about 50% of our cases, these point mutations of individual genes is present in about 80 to 90% of cases. So when looking at how these subclonal and clonal driver mutations occur in MDS, a few years ago, there was a paper that looked at 738 patients with MDS, and they sequenced out a little over 100 different genes associated with MDS or AML. And they were placed into the genes that were noticed were placed into these different categories, such as ribosomal proteins, epigenetic regulators, RNA splicing, transcription factors, and tumor suppressor genes. And we can see that about 90% of patients that had MDS had some sort of point mutation in one of these different categories of driver genes that were associated with MDS. You can also see that there are certain forms of MDS or certain prognostic features that are associated with certain mutations, such as the Sf3b1, which is correlating with the refractory anemia with ring sideroblasts. So with this, we're then able to look at the implication it has on the revised International Prognostic Scoring System, or the RIPSS. And generally speaking, the RIPSS splits patients apart in their prognosis based on their cytopenias, their chromosome abnormalities, and the number of blasts. But where do we put all this information that we now have based on next generation sequencing? And it turns out that when we plug in the mutations that are historically associated with poor prognoses, such as TP53 or ASXL1, we actually tease out a population of patients within each category that puts them at higher risk. So you can see with the mutations such as TP53, EZH2, ASXL1, if patients with very low risk or low risk MDS have these mutations, their survival is very different from the usual group of patients that would have low or very low risk IPSS-R scores. Also, looking at how many mutations a patient has can help predict the prognosis. So looking at this, the top three, the gray, the yellow, and the teal lines, look at 0, 1, and 2 driver mutations within MDS. And we can see that the leukemia-free survival takes the same path. However, with 3 or more mutations, the prognosis starts to drop. So the more genomic alterations we have, the more aggressive the disease course is going to be. And this starts at a very early time point, and that is the whole picture that we're looking at here, is that MDS really sits on a spectrum from normal hematopoiesis to malignancy. And generally with age, as the copy forward mechanism is occurring with genetic material, point mutations are happening at a slow rate. However, these background mutations are not going to have any kind of effect on clonal hematopoiesis until a mutation occurs in one of these driver genes, in which case we start to see clonal expansion. And that's where clonal hematopoiesis of indeterminate potential is found. And there's no malignancy or no dysplasia that's seen in the bone marrow, but we see clonal expansion with these driver mutations that are in the genetic material of these cells. And these chip-associated mutations are often seen with MDS, AML driver, leukemia driver genes, such as DNMT3A, TET2, ASXL1, JAK2, and TP53. So as these mutations occur, another sentinel event can happen with a cooperating mutation, which will then take the clone up and create more dysplasia and proliferation, leading to MDS and eventually AML. So basically placing our patient on this spectrum helps us decide what their overall course is going to be. So when looking at clonal hematopoiesis, there's a few different categories that precede the actual diagnosis of low risk or high risk MDS, and that includes clonal hematopoiesis of indeterminate potential, known as CHIP, idiopathic cytopenia of undetermined significance, or ICUS, or clonal cytopenia of undetermined significance, or CCUS. So when looking at the variant allele frequency here, we see that in order to establish clonality, we must have a variant allele frequency of at least 2% or greater. And we can see that with CHIP, CCUS, and MDS, since these are all clonal disorders. Dysplasia should only be seen in low risk or high risk MDS. So if it's less than 10%, it's either CHIP, ICUS, or CCUS. If it's greater than 10%, we're looking at an actual diagnosis of MDS. Cytopenias are generally not present with clonal hematopoiesis of indeterminate potential, but will be present with all the other diagnoses on this slide. Blasts, again, are indicative of higher risk disease and should not be seen with CHIP, ICUS, CCUS, and also low risk MDS. But with high risk MDS, obviously we see an increased set of blasts. And as you move through this spectrum, the more blasts and the more dysplasia there is, and the more mutations there are, the higher the risk, the transformation to AML. So again, looking at this from a spectrum standpoint, when there's mutations that we see in CCUS, those directly mirror what we see in MDS. So a lot of these splicing mutations, TET2, TP53, DNMT3A, the ones that we see in CCUS also are the ones that are seen in MDS, which tell us that there's some sort of driving force that is pushing these patients towards an actual diagnosis of myelodysplastic syndrome. And that's actually been borne out in data, where we took 154 patients that were cytopenic and did not have a myeloid neoplasm. However, 36% of them had one or more mutations in one of the leukemia driver genes, classifying them as CCUS. And those are the patients that had the highest probability of evolution to MDS or AML. And those patients that had Sf3b1, SRSF2, U2AF1, or a co-mutation with some of the higher risk mutations, such as DNMT3A, TET2, or ASXL1, those were the patients that had a higher risk of progressing on to MDS. So spending some time with CHIP, obviously there is a risk going towards MDS or AML when a patient has CHIP. But in a study of over 29,000 patients that were unselected for any kind of heme malignancy, the most common mutations that were seen were DNMT3A, TET2, and ASXL1. Interestingly, not all of these patients developed some kind of heme malignancy. However, their all-cause mortality was still high. So the question was, if they're not dying from MDS, which we now have a good pathogenic mechanism for, what are they dying of? And it turns out that they were dying of vascular complications. And when looking at the hazard ratio for death, for these people that have these DNMT3A, TET2, and ASXL1 mutations, the hazard ratio for death from coronary artery disease was 2, and from stroke it was 2.6. In additional studies looking at JAK2 mutations, the hazard ratio for death with coronary artery disease was 12. And when looking at the actual allelic burden of JAK2, the allelic burden of greater than 10 correlated with a higher risk. So not only is there a higher risk towards AML or MDS, there's also a higher risk of all-cause mortality from vasculopathic complications. And what is it that's causing these vasculopathic complications? And it turns out that it's inflammation that's driving the heart disease and the vessel damage. So normally in the bone marrow, we have these healthy hematopoietic stem cells, and when a mutation occurs in one of the driver genes, there's going to be clonal expansion, which eventually leads to spillage of these cells into the peripheral blood. It turns out that these peripheral blood's damaged cells will go into the vessels of the heart and create an inflammation. And when looking at RNA sequencing of cells that had loss of TET2 function, there was augmented expression of RNA that encoded for pro-inflammatory mediators, such as interleukin-1b and IL-6. Furthermore, looking at JAK2 mutations that had that were seen on granulocytes, there was activation of beta-1a and beta-2 integrins that mediated binding to the endothelial cells, where leukocytes were able to adhere tighter and create more vascular inflammation. So a lot of this all-cause mortality was the result of increased inflammation from mediators that were upregulated from leukemia driver genes. And looking at some of the data that's going to be presented this year at ASH is the Isocitrate dehydrogenase, or IDH mutation, as a driver of heart disease. So we know the mechanism of IDH mutation in AML is well elucidated. We know that a mutant IDH will result in the formation of a novel oncoprotein called 2-hydroxyglutarate. And 2-hydroxyglutarate actually has a relation to TET2, which we discussed in the prior slide. So in this observational study of 360 patients, IDH mutation, either IDH1 or 2 mutations, were seen in about 18% of people. And the patients that had an IDH1 mutation had a higher prevalence of coronary artery disease, and it was quite striking. 26% of patients versus 6.4% of patients that did not have the IDH1 mutation. And there was also an increased risk of decline in cardiac function when exposed to anthracyclines in patients that had a mutant IDH1 and 2 in their AML signature. So it turns out in the cell line studies, human cardiomyocytes that were exposed to anthracyclines were exposed to anthracyclines with or without the presence of 2-HG. And 2-HG exposure in the setting of anthracycline exposure led to greater sarcomere disarray, which is essentially damage of the cardiomyocytes. So there's something about the 2-HG that's leading to increased cardiac dysfunction that will lead to increased cardiac complications. And this is data that will be presented this weekend. So in summary, diagnosing MDS remains challenging, but is a crucial first step. Significance of point mutations in MDS is largely elucidated, and there's a ton of information that's available, but it's still immature, and we are unclear on how to incorporate it into the existing morphologic classification. And I think the new guidelines that will come out will now start including mutations such as Sf3b1 in the classification of myelodysplastic syndrome. But we do need to integrate this new information into treatment options and prognostic scoring systems, so we have better discussions with our patients and better therapy choices for them. Clonal hematopoiesis has implications beyond the hematopoietic stem cell system. I hope I showed you that CHIP does lead to MDS. However, these leukemia driver genes can result in all-cause mortality due to increased inflammation. So with that, I will hand it back to Dr. Gore.
Thank you so much, Prapti, for a really illuminating and very clear talk. I think the topic of these various blank cusses is very confusing to many practitioners. I think you spelled it out really quite beautifully. And I'd mentioned that at the end of this, the presentations that we've talked about, I'm going to give a little bit of update about the National Heart, Lung, and Blood Institute's natural history study, just to focus on how much CCUS is being seen in that study. And I think that'll be interesting to round out or to come back to your topic. Well, let's start with a case, a patient named Jim, who is young at 52. I guess I would agree with that nowadays. And he had a history of increasing fatigue and was found to have a macrocytic anemia. His past history showed fatty liver disease and a reasonably significant smoking history. A bone marrow eventually was performed, which was hypercellular, and dyserythropoiesis was seen, not a very high number of blasts. Megakaryocytes were increased and were atypical. And upon iron stain, significant number of ring sideroblasts, certainly greater than 15% or 25% in this case, were found. With normal karyotype and on an NGS panel, an Sf3b1 mutation was uncovered. The patient was anemic with a hemoglobin of 8.3 and had a moderate transfusion burden. So Prapti, why don't you tell us how you integrate this clinical information?
Sure. So we have our conventional scoring system with the Ipssr, which, like I said, takes into account the cytogenetics, the bone marrow blasts, and the various cytopenias that patients can present with. So he had normal cytogenetics, which puts him in the good risk category and gives him a score of 1. He had only 3% blasts, so again, another score of 1. And the only cytopenia that he had that was significant was the hemoglobin between 8 and 10. So that gives him a low risk score. And so one of the things, like I said in the earlier part of my talk, is that this does not take into account a couple of things that were mentioned in his presentation. And that's the ring sideroblasts of over 25%, also the Sf3b1 mutation. So this is where incorporating the genomic characteristics becomes very important, because it can help drive, talks about prognosis and also therapy selection. So Sf3b1 is a spliceosome mutation. and it's considered the initiating genetic event in the development of MDS. It's usually associated with ring sideroblasts, and it leads to an ineffective erythropoiesis. And so that's why we see an overwhelming majority of these patients with a deep anemia, but usually their other blood counts are okay. And so when you look at patients that have Sf3b1 mutations, you can see here in terms of overall survival, comparing the survival of patients with Sf3b1 in the red versus those all-comers with MDS that have a wild-type Sf3b1, the survival is a little bit better. And then same thing in patients that have refractory anemia with ring sideroblasts, which is our WHO classification, with or with in this red line and without the Sf3b1 in this blue line. And again, the survival curves start to split apart. So we know that even though this isn't something that's integrated into our RIPSS, that this genomic alteration is going to carry prognostic significance. So this is why I think it's important to prioritize the genetic characteristics when talking about therapeutic interventions for these patients.
Yeah, well, that's very good. But one thing that I was thinking about as I was watching your slides, and here's another one, is that these good risk MDS, so-called, there weren't many people alive at 8 years. And if I'm Jim and I'm 51, I'm not thinking that's very good prognosis at all.
Yes, so that's true. But there are some disease-altering therapies that are there that can increase survival, such as hypomethylating agents. So if I'm Jim and my curative option is allogeneic stem cell transplant with at best case scenario, 2-year mortality of 20%, and knowing that I'll still be around if I don't go to transplant with this low risk MDS, the way I look at this is that I would want to use up all the other weapons in my arsenal to keep me going and use stem cell transplant, which is my curative option, as a last resort.
Yeah. Well, back to our patient. As we've heard, apparently somebody's found out that he was resistant to erythropoietic stimulating agents, and some very aggressive practitioner did do HLA typing, given his age, I guess, and found that the sister was HLA matched. So what should we counsel him? I'm very reluctant to transplant patients this early, but maybe I'm a old fogey.
So I agree with you. As a transplanter, I've had many intermediate risk transplant go wrong, and my general practice is to shy away from transplant with anybody that has low risk MDS that would have another option for therapy available, because we know that a lot of these other therapies that I'll discuss in a second can improve quality of life and decrease transfusion burden, which is really the most limiting factor for our patients with refractory anemia and low risk MDS, is the transfusion burden and the fatigue that comes with it. So my general practice is to focus on modifying the quality of life for patients with low risk MDS, because we know their chance of transformation to AML is rather low. So when looking at the treatment options, I would tend to move away from allogeneic stem cell transplant. And then starting at the top with azacitidine, this is a disease-modifying agent, and he really doesn't have other cytopenias. He doesn't have a lot of aggressive-looking dysplasia or blasts on his bone marrow. And so to subject him to the side effects of a hypomethylating agent when his other cell counts are reasonable, I think there are other options that are available, and that's where I would call people's attention to lenalidomide or to luspatercept. So lenalidomide is historically seen as the drug for 5q- syndrome, but also in studies it's shown that refractory anemia with ring sideroblast tends to have a pretty decent response to lenalidomide. And with the recent FDA approval of luspatercept that I think we're going to be talking about in a couple of minutes, again, Sf3b1 mutation and ring sideroblasts over 15% tend to respond to luspatercept. So here we have two drugs that are relatively easy to dose, have few side effects, and won't alter the quality of life of most patients. So if I were to pick one, I would go with luspatercept as my next choice for somebody that's ESA resistant. And I'd like to hear what the other panelists think too.
Any comments from the other panelists?
No, Dr. Patel, I think that's on the money. The use of luspatercept in patients with Sf3b1 mutations has certainly become standard care in ESA resistance, or in patients who have an EPO level that's very high before starting, and that was the trial population. But what's interesting is the trial population didn't include patients who were thought to be getting the best benefit from lenolinamide, which is those 5q minus patients. And this patient isn't a 5q minus patient, but certainly patients who don't have 5q that have lower risk disease have been treated with lenolinamide for many years, often very successfully. And as we'll talk about in a minute, the ECOG 2905 study revealed that, when patients stop responding to erythropoietin stimulating agents, they can remarkably be resensitized with the addition of lenolinamide, better than getting lenolinamide alone. So that's another consideration, is the combination of ESAs and with lenolinamide here.
David, any comments from you?
Nothing else to add on this case.
Yeah, I think we could have a long conversation about how useful lenolinamide is in this group, but I think we're limited by time, and hopefully Mike, you'll have some time to talk about it. I'm also interested to hear what you and David think about the use of azonucleosides in low-risk patients where it's effective, but it sure gives me worries about what we're doing to these people's genomes, but more to come. So we have a couple questions from the audience, and one is, Prapti, how do you differentiate between late-onset inherited marrow failure syndromes from acquired MDS? Who should we screen for telomere dysfunction, for example? Whom should we be screening for latent Fanconi's?
So that's actually a really good question. It's one of my clinical interests. Historically in medical school and fellowship, we've all been taught that these inherited bone marrow failure syndromes present early in life and have certain pathognomonic physical exam findings. And if we don't see those, then those aren't on our radar. But I think now we're starting to find that this is a heterogeneous group of patients that can have germline disorders with that result in telomere biology disorders and have no physical exam finding, for example, the early graying or oral leukoplakia or anything like that. So the other thing that kind of throws a wrench in this that makes the diagnosis difficult is that within one family, as this gene is being passed around, some patients will have very early onset MDS and some patients will have nothing, and their CBCs continue to be stable well into their 70s. So the heterogeneity of the clinical presentation and the physical exam really make the diagnosis difficult. But I think a good family history is very important here. So in my practice, when I'm seeing any patient with a myeloid malignancy, I'm doing a very detailed history, not just saying, do you have any cancer, but asking about patients that have family members that have had unexplained cytopenias, unexplained ITP, which has been steroid resistant, or any other kind of disorder, just saying any anemia. And for people that have a family history of this, usually it's a first-degree family member or 2 second-degree family members. Those are the patients that need to be screened for inherited marrow failure syndromes and sent to a specialty clinic where this is done. So I definitely think it needs to be on the radar for everyone.
Yeah. David, do you agree with that? Is there any age cutoff for presentation of MDS where you just think patients should be screened regardless of family history?
I think what's important, our next-gen sequencing panels are continuing to be more and more comprehensive. So I really think what will partially help is just really including all the genes that, can. So for example, DDX41 can have no family history and can potentially present with late onset, myelodysplastic syndrome. And it's almost always, familial, when you see it. So I think it's a good example that we probably
it's quite common, really, isn't it?
It's not common, but I think,
the most common among these inherited
Correct.
disorders.
Yeah, correct. I just think we're probably missing, some cases. I think anytime you have an allele frequency at 50% with one of these potential genes, it's something to think about.
I guess I would add that, I think Prapti hit the nail on the head and said these patients should, if you're really concerned, should be referred to a specialty clinic, because I agree that the next-gen sequencing panels are getting better and better, but there are a lot of things like telomere length, specialized that you just can't find on these tests. And if you're not at a tertiary center doing this kind of work, these can be really tricky to pick up. I had recently a professional athlete who was 49 years old who had a grandmother with leukemia, and I just checked his telomere length, and he was 1 percentile, and he has atypical disc keratosis. He'd been to 5 centers, and if he would have been transplanted with a full intensity transplant, he would have been in trouble. So, these are sometimes subtle findings in people like Prapti said that don't have any symptoms or signs of the disease at all.
And I guess the other corollary to that, Mike, is that if you're considering such a patient for allogeneic stem cell transplant, it really behooves you, if it's a sibling donor, to screen the donor, because they may have no clinical symptoms and you don't want to give them back the same.
Well, that's another can of worms.
A lot of worms. With that, I'd like to introduce the gentleman that you just heard from, Dr. Mike Savona, good friend of mine from Vanderbilt, where he's chief of hematology, cellular therapy, and stem cell transplantation, director of hematology research, and the early therapy program. Phew. Mike, take it away.
Thanks so much, Steve. It's a pleasure to be here with all of you. And I'm going to talk about strategies with standard care clinical therapy for MDS. And, for many years of my career, that's really not been a very long conversation. There's just a couple drugs that have been approved and others that aren't approved that we use. But in the last couple of years, there's been a lot of activity at the FDA. And as Dr. Salmon will talk about at the end of our program, there's several more that are going to be on the way very soon, expected to be approved for this disease, making it more and more complex, but ultimately better for patients. So let me start by talking about addressing anemia. And that's kind of how I've broken this down into, lower risk standard of care treatment and then a higher risk standard of care treatment. And we'll bring it together with a case at the end. There really are still limited treatment options. ESAs are really the standard of care in Europe and the United States, despite the lack of a label. And, we use them all the time. Some of you use them quite expertly with great effect for many years. The thing that I find is that it's often in the community patients, max out at 40,000 units of erythropoietin and then they stop. And that doesn't mean they're not going to respond anymore. They just might need more of a dose. And I have patients who are on as much as 500 micrograms every couple of weeks with darbepoetin. So, you could get a bigger dose, 60, 80,000 units of an ESA of erythropoietin. Obviously, RBC transfusions have a rate of diminishing returns. They come with a burden for the patient, iron overload, risk of transfusion reaction, and over time, increasing number of alloantibodies. When we think about the types of treatment, and this was alluded to in the last talk, there's lots of considerations. There is where the patient is. They've just been told they have cancer. Often these patients are in their 70s and 80s. They want to know what their quality of life is going to be like. What is their performance status? What are their other comorbidities? Often patients with MDS, sometimes with DNMT3A or TET2 mutations, have baseline cardiovascular disease that may put them at higher risk in their myelodysplastic syndrome. A lot of my patients, I run a consultancy practice. A lot of my patients come from many hours away. So coming to see me and get treated is, how does that impact their quality of life and their financial situation? And then from a pathophysiology standpoint, it's our job to figure out just how dangerous this disease is, at least by the molecular epidemiology that we understand. So I'll talk briefly about ESAs. I won't spend too much time on this therapy that's been around for 40 years. But in short, the main key with erythropoietin stimulating agents is that they probably won't work if someone has a high baseline EPO, but they're worth trying because there's a very low morbidity associated with the therapy. And then it's important to know that if we do have success with the drug, we need to have parameters to hold the drug to not continue to give ESAs if someone's hemoglobin is rising into the normal range. And we learned that in the 90s and early 2000s where patients were super therapeutic dosed and there was an increase in VTs and death in breast cancer patients, renal patients. Moving on to lenalidomide, this is results from the MDS 0405 study published by Pierre. This one was published by Pierre Finot in 2011 in Blood. And this is a randomization between 2 doses of lenalidomide or placebo, and there's a lot of confusion here. Just the intention to treat population is the one to basically follow, and you can see that with the protocol-defined transfusion independence in the left panel, that basically people on placebo, no one is transfusion independent after being transfusion dependent prior to starting study, and about a third to a half of the patients on lenalidomide become transfusion independent. And it wasn't just transfusion independence, but there was increase in hemoglobin and some uncommon cytogenetic remissions. And really this led to the common use of lenalidomide in lower risk patients, both with the 5q minus and without the 5q. Importantly, lenalidomide was thought not to work in more complex cytogenetics, and while that probably is true, in lower risk patients with less complex cytogenetics who have non-deletion 5q, there's still activity in this disease with this drug. And I mentioned in the question and answer at the last talk that lenalidomide can reinvigorate response to erythropoietin better than lenalidomide alone. So a lot of patients were in this study randomized to receive lenalidomide versus EPO once they develop ESA resistance. And quite simply, the patients who had, and this is in non-deletion 5q, mind you, who had lenalidomide plus erythropoietin had a superior erythroid response, really, a double of the response that they expected to receive with lenalidomide alone. So moving to the last treatment for anemia, and I'm not talking about iron chelation today, but that is something that's part and parcel of every hematologist briefcase for sure. But with regard to luspatercept, so luspatercept is a very interesting drug. It's this fusion protein that has a modified activin receptor that is a sync for activin, which stimulates SMAD3 or SMAD2 and 3, which are inhibitory to late erythropoiesis. So it's a double negative. So if you remove the stimulation of the inhibitor, then you get improved late stage erythropoiesis. And in fact, that's happened and borne out in early phase 1 and phase 2 studies across low risk MDS with and without ring sideroblast. The most activity was seen in patients with ring sideroblast and thought to be Sf3b1, and the phase 3 Methyl study was conducted in patients who had low risk disease, had Sf3b1 mutation or ring sideroblast as defined in the left panel, and did not have 5q minus. So the sponsors of this study were clear that they did not want to put patients on this luspatercept who would be potentially robbed of a very good response from lenalidomide, and lenalidomide is the drug of choice for patients with 5q minus MDS. So these patients were randomized in a 2-to-1 fashion to luspatercept or placebo. And we wrote this study like this because we had such compelling phase 2 data, we didn't feel it was ethical to have a 50-50 randomization. And this was kind of the bargain that was made, 2-to-1 randomization. And in fact, in the phase 3, the number of patients who were independent from red cell transfusion after a short, 8 weeks, and then at the, at the endpoint of 24 weeks of the study, was far, far better than placebo. And this ultimately led to our New England Journal publication and also the approval of luspatercept for this indication. If you look at the changes in hemoglobin over time for patients who had luspatercept, there's a response that people get pretty much right away, and that response is held for a long period of time. And that's helpful because, if you're 3 cycles in and 3 cycles in and patient has increased fatigue, which is really one of the only adverse events of note from the study, then you're probably not going to get a response and should consider abandoning it. If you do get a response, however, there's a chance that response may improve beyond that 24 weeks if they're able to stay on the drug, indicated here where the mean change from baseline RBC units transfused is actually far better in the patients who are monitored out to close to a year. Okay, so that's all I'm going to say about approved therapy for anemia. Let's talk about DNA methyltransferase inhibitors. And, this is no news to anyone here listening, but we use azacitidine and decitabine as a backbone of therapy based on AZA001, published by Lou Silverman now almost 20 years ago on the left, that showed a hardly reproducible EFS and OS benefit for azacitidine of 20 months. And then decitabine, which showed a EFS and survival benefit that was not statistically significant, but this did become part of the standard care for MDS in the United States. And I'm not going to get into the differences between decitabine and azacitidine in that vein, except to say that they're both acceptable used for patients who need disease-modifying therapy. Now, what has been done recently to help improve the delivery? Well, this is the backbone we have, and Dr. Sama will talk about how you can kind of add some muscle to that backbone and really improve your responses. But before we had all these fancy new drugs, we had to think about, well, how do we make the backbone itself stronger? And really, there's been a couple of different approaches. One is to change the bioavailability of DNMTIs entirely by delivering them either subcutaneously, like guadocytabine. Turned out to be a negative trial, but there's probably activity in guadocytabine in certain patient populations that we shouldn't ignore. And then CC486, which is a drug that's recently approved for maintenance in patients who are over 55 and receive a complete remission, but can't receive the remainder of their consolidation therapy for AML. This is not the equivalent to azacitidine. It's a very different drug. But as Dr. Sun will also talk about, because of the early work we did with CC46, we learned the methylogram is different, and there's ways to employ this drug to maybe get a different signal and work in places where azacitidine did not. On the other side of this graph, you can see different approaches. We've started with CC46 and we try to approximate azacitidine parentally with oral azacitidine. That really didn't work for reasons I'll get into. But there's been additional attempts. 727, which is a now approved drug, Aztec 727, which is oral decitabine plus cedazuridine, a cytidine deaminase inhibitor. And Aztec 030, which is oral azacitidine plus the same inhibitor, is in a phase 1 clinical trial right now. So if you haven't heard about cedazuridine, this is the drug that basically is the candy coating on the outside of the chewy center of decitabine. So as the decitabine is ingested, the cytidine deaminase inhibitor cedazuridine then deactivates cytidine deaminase, which is the drug that shuts down decitabine if it were to be given naked orally alone. So you have this inactive metabolite. And we've learned through phase 1 and phase 2 studies, we can approximate the bioavailability pretty good. This is a study that we did a few years ago, a phase 1 study, and you can see if you've got really good eyesight, the difference between these lines that basically show that as we march up the cedazuridine dose and the decitabine dose, we can get closer to approximating the AUC of the parenteral decitabine. And that's the phase 1 task, right? The phase 2 task was then validating the bioavailability that we thought we had. And it turns out that the 20 milligrams of decitabine, the 30 milligrams of decitabine and the 100 milligrams of cedazuridine was too low, and the 40 milligrams of decitabine and the 100 milligrams of cedazuridine was too high. So we went right in the middle. 35 milligrams of decitabine with 100 milligrams of cedazuridine. The phase 2, the first part validated that, and then we made a fixed dose combination, and that's Aztec 727, the pill, which was further validated in a phase 3 study called Ascertain. Ascertain is a study that included patients. It's interesting to look at the inclusion criteria on the left panel of your screen, where patients with intermediate and high risk MDS and CMML, as well as RABE-T, the old RABE-T, 20 to 30% blast, now considered AML. As long as patients had less than 2 cycles of therapy, they could go on this and be randomized. And they were randomized basically to sequence A or sequence B. In sequence A, they got oral first, and then IV. In sequence B, IV, then oral. And this is basically, and then from there on out, they got the oral. That was the carrot to go on the study. And the FDA mandated AUC, oral IV AUC equivalence was 90% with a confidence interval from 80 to 120%. And as presented last year by my partner on this study, Guillermo Garcia-Manero, the ratio geometric least square mean for the oral to IV turned out to be 98.9%, far exceeding expectations with a confidence interval of 92.7 to 105.6. So I think we really showed that this drug is equivalent from a PK perspective. I'm not showing you here, but it's equivalent from a PD perspective. What about efficacy? Well, last year we showed preliminary efficacy, which showed a CR rate that was a little on the disappointingly low side, 12%, with an overall response rate of about 30%. We will be presenting the updated efficacy data at this meeting. It's suffice to say it's improved dramatically as more patients who weren't evaluable for response yet at the time of the last presentation are now evaluable and ready to present. As we expected, there weren't really increased risks of any kind of toxicity that we don't normally see with IV parenteral given azacitidine or decitabine. Now, I'll briefly go to talk about CC46, which is naked oral azacitidine, and this will set up Dr. Salmon's presentation of his alternative dosing CC46 study very well. So this is a study that actually Dr. Gore was a key participant in, published now almost 10 years ago. And the idea was to give oral azacitidine and overwhelm cytidine deaminase without giving an inhibitor. And no matter how much azacitidine you gave in this study, the AUC couldn't be matched. And at some point, you were limited by GI toxicity. What's interesting in this study is that there was, with this dosing, a difference between the effects on gene transcription with the sub-Q and the IV and the oral. And even though this drug shouldn't be considered equivalent to parenteral azacitidine, these divergent effects on gene transcription got us thinking about different ways to explore this drug in MDS. And in our early extension phase 1 extension studies, we tested CC46 at vastly different doses and regimens, 14, 21 days. And you can see that you get a considerable change in mean demethylation, even to the naked eye there at different points in the cycle. And those different changes in methylation really do affect gene transcription. So, with respect to anemia, ESAs are still standard of care. You should keep them in your Rolodex for sure. Lenolinamide is very effective in 5Q-. In non-5Q-, if you're adding it on after ESA failure, maybe you should keep the ES on too, because in combination, 2905 made that look pretty darn good. Luspatercept is a great new option. David will talk a little bit about a couple new things, but there's a lot of exciting erythropoiesis stimulants and scavengers that are going to be coming into phase 2 trials very soon to improve anemia response in MDS. With respect to DNMTIs, they are still the backbone of patients who need disease-modifying therapy. Novel combinations are the key. These drugs are great, but the responses we're seeing in combinations are blowing them out of the water, and it's a very exciting time to do MDS. With respect to maximizing delivery, 727 is equivalent to decitabine, and it's already revolutionizing care in standard practice because people can get their drug and go home and don't have to sit in a chair for 5 days in a row to get IV decitabine, and that's really improving quality of life. 030, we'll see if that same bar can be met as was met with 727. But it's really important take-home message to know that CC46 is not equivalent to azacitidine. It's a totally different drug. It's not approved for MDS and cannot be substituted for parenteral azacitidine in MDS. Its approval is in maintenance for AML patients over 55 who reach remission and cannot continue to receive intensive chemotherapy. So in summary, we got effective therapy for MDS. It's I haven't been able to say that for many years, but we do have effective therapy and it's getting better. We can be more thoughtful about the tools we have. We have more tools for sure, and we can find ways to combine them. DNMTIs are still the backbone, but as David will tell you, with the addition of these new agents, we're really going to improve response, quality of life, and ultimately survival in this disease. Thank you for your attention. It was a pleasure to speak with you.
Thanks, Mike. That was a really wonderful talk, as always, and very illuminating, I think, discussion, which I think, I think even though a lot of these drugs have been around for a while, there's still a lot of confusion about which ones to use and when and how. So I'd like to go straight to our case here. A woman named Sam, sort of like a boy named Sue, who is a 64-year-old woman with a history of stage 3 breast cancer, developing fatigue, showing macrocytic anemia with normal platelets and essentially normal white count neutrophils, and lower tick count, leading to a bone marrow, which was moderately hypercellular for her age, some atypia, rare ring sideroblasts, but really insufficient dysplasia to call MDS morphologically, normal karyotype. And she had next-gen sequencing, which showed several mutations, including Sf3b1, DNMT3A. So Mike, what do we call this?
Yeah, so it's a little bit of an accident, but I have to say this goes very well with Prapti's talk about, very nice talk about clonal hematopoiesis before. And, where a lot of, 10% of people over 70 have CHIP, but obviously the rates of MDS are much, much lower. So most people with CHIP never get MDS. Likewise, there are a lot of patients with CCUS, and there are some that are higher risk than others. This is a kind of like a barks like a dog, smells like a dog scenario. This is a patient who got anthracycline therapy and has not just an Sf3b1 mutation, but a DNMT3A mutation. This is, and in the absence of dysplasia, isn't dysplasia, but it is CCUS. There is some debate about whether or not an ANC of 1,000 or 1,500 or just below normal values counts as CCUS, but I think most of us would call this patient CCUS with a high likelihood of developing MDS.
I agree. Well, what happened? She came back a year later, feeling a little worse, and similar counts, it would seem. High EPO level, which would argue that she would probably not respond to an ESA. So we have some choices. We could transfuse her, we could give her ESAs, we could use luspatercept since we know she's not likely to respond to ESAs. Somebody wants to transplant her, somebody wants to give her methyl transferase inhibitors. What's a doctor to do?
So, I think I choose the Dr. Patel School of Medicine here, and I just give the patient luspatercept. But, unlike her 52-year-old who's probably got better reserve and less morbidities and a less nasty genetic profile, the writing is on the wall. This patient is probably going to need a transplant. And one thing that's important to remember is that, and this is always the tricky thing, as patients age out of eligibility for transplant, we don't want to miss that opportunity. So, certainly wouldn't pull the trigger for her quite yet. She still got some years of eligibility and would try luspatercept.
All right. So, well, she gets up to a good age at 67, and she had a nice hematologic improvement to luspatercept lasting about a year. But it dropped off again, and now she's got worrisome thrombocytopenia and neutropenia. And she's quite dysplastic with 15% blasts, and now she's got awful mutations including TP53, Sybil, and ASXL1. So, what do we do with this lady at this point, Mike?
Well, this is what I meant about the writing on the wall. And, you're damned if you do and damned if you don't. You transplant someone too early and they have toxicity, you wish you never did it. if you take someone and wait till they have a TP53 mutation, which puts them at high risk for with transplant, as Coleman Lindsley published several years ago, then you think, well, you waited too long. So this is an EB2 case. Dr. Salman will talk at great length about the combinations that we can use in this patient. And luckily, I think we actually have some hope there that we really had less of before. But I would give this patient a novel combination, hopefully on clinical trial if there's one available, and then take them to transplant.
Right. And, I don't think we have any formal discussion of the previous mathematical models to look about when to transplant low-risk patients, but certainly back in the day before our current drugs, but even including azacitidine in the more recent study, there wasn't really any net benefit to transplanting such patients early.
Corey Cutler's paper on IPSS and transplant is now over 20 years old, and it's still important. And, basically high-risk patients benefit from transplant, low-risk don't, and intermediate, we don't know. And right. I think we're getting more clues to help us with that. And the new drugs got to buy us a little time, but we're still not clear on those folks.
Yeah. Mike, I'd like to ask you a question. Now that we have these oral azonucleosides and they're quite effective, I'm pretty sure that we're going to see a lot of low-risk MDS patients who are anemic getting Aztec 727. Is that a good idea?
I would say no. I think that you should look at your patient and say, is this a patient I would give azacitidine or decitabine to?
Yeah, but it's so easy. I mean, I don't have to give them shots.
Yeah, well, it's so easy to give capecitabine to people too, Steve, but you don't give it to people if they don't have whatever they give capecitabine, some kind of colon cancer or something. Well, I don't take care of colon cancer, but I think that, this is a drug that, you're sending a patient home with a drug that can ablate their marrow. So it has to be used accordingly and safely. And it's really an important point you raise. We have to be careful and disciplined just because we have an oral equivalent not to use the drug outside of its indication. And the nice thing is that, as we get smarter, there'll be different ways to mix that fixed dose combination to, say, maybe metronomic dosing, but that data is still not out. We don't know if low doses of oral decitabine for low-risk patients is worth a damn, and it's not on the market.
And do we have any long-term follow-up on these patients, lower-risk patients who've received these drugs, in terms of whether there may be some acceleration of genetic progression, for example?
You're leading me. So there's been a couple reports, of azonucleosides and genetic damage. I mean, these are tough studies, right? I mean, it's a little bit of a biased thing because maybe the patients who got the drug, and kind of like the hydroxyurea argument, if the patients got the drug, they were more likely to have genetic evolution in the first place. But yes, there is an increased risk of genetic evolution and cytogenetic changes in patients who are alive, who received azonucleosides, maybe when they shouldn't have, maybe when they were low-risk patients.
Well, it's the privilege of the chair to try to bias the discussion a little bit, but you're always welcome to push back. All right. With that little interchange, I would like to introduce yet another friend, David Salman from the Moffitt Cancer Center. And David's done some spectacular work with some of our newer drugs and some of our worst molecular subtypes of MDS. So David, let's hear about it.
Thank you for the introduction, Steve, and it's really a pleasure to be speaking here this morning. So I think this figure doesn't cover all of the potential targets, but it's just to really highlight how rapidly the field of myelodysplastic syndrome is coming along, both with targeted inhibitors for specific mutation classes, really a lot of novel immuno-oncology agents being investigated, and others. But really, again, I think a lot of excitement in really moving the field forward. And although a lot of our talk is going to focus on HMA-based combinations, particularly for high-risk patients, just want to highlight a couple of low-risk studies and piggyback a little bit after Dr. Savona's talk. So, as he mentioned, CC486 has been evaluated in myelodysplastic syndrome. This is a recent presentation at EHA by Dr. Garcia Monero and colleagues of a phase 3 study looking again at CC486 in low-risk MDS patients at the 21-day schedule at 300 milligrams daily versus placebo, with transfusion independence being the primary endpoint. And I think what's notable is, the trial actually does reach, its statistical primary endpoint of improved transfusion independence. I think this is not necessarily surprising, as we know really HMA as a class does have response rates. And notably, the responses, were durable. You can see a duration of response with CC486 of 11 months, although not statistically significant here. A little bit further breakdown, not only did they meet their primary endpoint, but again, you could have platelet response as well, which is not necessarily unexpected. But I think unfortunately there were some, I think maybe to Dr. Gore's point earlier, is that there were a higher amount of early deaths in the CC486 arm, and these were largely related to infectious-related complications, and thus this trial was closed early. And so again, CC486 is not approved for MDS, and I think we know in lower risk patients when HMA is indicated, I think there's still a lot of research going into what's the optimal schedule, and potentially lower schedule or less duration of hypomethylating agent may get you an adequate response without necessarily the myelosuppressive toxicity. So again, further work really needed to evaluate CC486 in low risk MDS. Another agent, just to go on, what can we have for transfusion-dependent anemia patients? Of course, we've heard about luspatercept at some length, but another agent is Imatillostat, which is a telomerase inhibitor. Again, this is a trial where the phase 2 data were presented, where all patients got drug every 4 weeks. This was for low-risk MDS patients. They also had to be HMA and Len naive, and it was a 2-to-1 randomization, or this was the phase 2 part of the drug. And then based on these data, ultimately the phase 3 part has been initiated, which is a 2-to-1 randomization versus placebo. And so as far as 8-week transfusion independence, a high percentage of patients did achieve response at 42%. And I think maybe what's most noteworthy is thinking about the longer duration. So if we look at 1 year transfusion independence, roughly a third of patients, have remained transfusion independent. I think this durability has been part of the excitement, with this agent. And again, we look forward to seeing the phase 3 results as those will come out later down the road. So I think this was highlighted nicely in Dr. Patel's talk. Of course, the vast majority of patients will have mutations. I think in particular, we'll like to highlight TP53, which again is this molecular cohort with the poorest of outcomes. And I think it's something to think about when we think of HMA combinations, kind of TP53 mutant and TP53 wild type cohorts. But there's lots of agents, and I think a lot of the data that we're seeing right now are response rates, but how can we potentially look at early biomarkers that may ultimately predict, how patients may do down the road. So this is work that we've been doing recently where we looked at all patients where we've performed serial sequencing, and this is not at MRD depths, this is just with commercial sequencing with variant allele frequency at 5%. And what we saw in both high-risk MDS and secondary AML patients was really the achievement of NGS negativity was really a robust biomarker to predict for improved overall survival, which was still independent in multivariable analysis. And if you look at patients that were NGS negative at their last assessment, you can see the vast majority of patients were alive. I think importantly, we also, when we think of TP53, really the serial or the dynamic of the clonal burden of P53 is really intimately tied to the patient's clinical trajectory. We kind of looked at this a number of ways. So a patient that has sort of a low durable allele frequency, and I'm going to comment on that in the subsequent slides, can actually have reasonable outcomes. And then flip, I think when we think about patients on treatment, the ability to achieve negativity, you can see patients with P53, have improved overall survival. And again, these were also independently prognostic. So when we think about variant allele frequency, what are the cutoffs? How does this predict prognosis? We'd show this several years where patients with an allele burden over 40% had, significantly, dismal outcomes versus patients with allele burden less than 20% could actually have some durable decent overall survival. I think this was nicely recently shown by the MD Anderson group, again with relatively similar VAF thresholds, and they were actually able to incorporate each allele percentage increase into a multivariable model, just really showing how dynamic the P53 clonal burden is on prognosis. And then really recent elegant work on behalf of the International Working Group Molecular Committee, this is by Bernard and colleagues, really looks at the allelic state of p53, and really what they clearly show is patients that have biallelic p53 mutations, which could be a mutation of both alleles or sort of loss of heterozygosity through deletion 17p or minus 17, is that those are the patients that really have poor outcomes. Although this is highly concordant with allele frequency, if you look in the supplement, really patients with an allele frequency of over 23% had poor outcomes. And what we know this have really looked at the high-risk cohort. So if you are complex karyotype, high allele burden, biallelic, really this is the group that does poor and is probably about 80 to 90% when we're thinking about the high-risk trials that we'll talk about in subsequent slides. So now I'd really like to look into several agents that are showing synergy in the combination perspective. This is not all-inclusive. I think there are several others, such as TIM3 inhibitors with sabatolimab and others that I won't have time to cover. But we're just going to briefly get into some of the data. So pevonedistat is a novel small molecule inhibitor of NED8 activating enzyme. NED8 activating enzyme processes NED8 and actually able to target multiple targets, the main ones likely being colon ring 3 ubiquitin ligases, which ultimately target proteins for the proteasome. And thus pevonedistat, by inhibiting this pathway, really leads to this accumulation of substrates, which has sort of direct inhibition of proliferation in both MDS and AML. And there are multiple trials ongoing. These are data that were just recently presented at ENA by Lenolinamide. And this is a phase 2 randomized trial that did include both higher risk MDS patients, but also CMML as well as oligoblastic AML. This is an HMA naive patient population. And it was a randomization that was open label to pevonedistat with standard azacitidine schedule with a primary endpoint of event-free survival. And so in the high-risk MDS patient population specific, which is the Kaplan-Meier curves on the left, you can see that they did reach statistical significance and an EFS of 20 months in the combination arm versus about 15 months in the azacitidine arm, and sort of a trend for overall survival, but again, that was not statistically significant. And sort of the responses to data really led to the phase 3 Panther trial, which I think we're all excited may read out in 2021. And again, EFS is the primary endpoint. And just looking a little bit more at some of the data, what are the responses? So I think overall a high percentage of patients are responded, as you see at 80%. And I think what's notable is looking at true complete remissions by IWG criteria is that the CR rate is 50%. Clearly, over double of what we would expect with standard azacitidine. Additionally, the responses are quite durable in the combination arm. And I think safety is really paramount anytime we're thinking about combinations, as we may have multiple agents approved in the pipeline. I think these may be some of the considerations, but really versus azacitidine monotherapy, you could see that there was really no, in general, AE or more severe AE that was really significantly increased in the combination arm, including no worsening of cytopenias. And so with that, I'd like to focus more to a p53 specific agent. This is APR246 or epernetapop, which is a first-in-class p53 reactivator. It basically can form cysteine bonds with sort of the mutant and unfolded protein and really leads to a thermodynamic stabilization and an overall shifting to wild-type function for p53 to do normal activity such as cell cycle arrest and apoptosis. And this, we have led a phase 1b/2 clinical trial of combination in p53 mutant MDS in oligoblastic patients. The phase 1 really ultimately leading with a 4,500 milligram fixed dose, which is given intravenous on days 1 to 4, sequentially with azacitidine starting on day 4. And just to briefly go over the data, so you can see the swimmer's plot in the upper left, but when we look at the MDS and AML patients, again, the vast majority of patients responding with a true complete remission rate in the 50 to 60% across patients and a duration of response in the 7 to 8 month range. I think notably a high percentage of patients came off the transplant, and I think these are critical analyses that are ongoing. Historically, maybe 10% of this patient group may go to transplant. It's a very challenging group as far as relapse after transplant. I think similarly like to just highlight a really parallel phase 2 trial by the GFM led by Thomas Clouzot and colleagues. Again, really was the identical patient population, although they did include patients with over 30% blasts and did have a maintenance arm for patients that proceeded to transplant. And really in the ITT, particularly in the MDS and the oligoblastic patient population, you could see the CR rate really quite identical in the sort of 50 to 60%. And although there's only a few patients that had over 30%, the response rates were less, and potentially some of these patients may have been more rapid progressors, but I think more data is needed in that setting. But based on both of these phase 2 trials, a phase 3 trial of combination versus azacitidine alone has actually completed accrual, and we anticipate data readout by the end of the year, and the primary endpoint of that trial is complete remission. So another frontline agent that we've been closely involved is Mcgrolomab, which is a CD47 inhibitor and basically blocks a don't eat me signal, ultimately leading to activation of macrophage-mediated phagocytosis. And thus we've now presented several times and more recently at EHA and ASCO of frontline combination data, again, both in unfit AML patients as well in high-risk MDS. And as far as safety, the really only notable unique toxicity of Mcgrolomab is on-target anemia. So old red blood cells do express pro-eat-me signals as sort of our body's normal way to get rid of them. And thus with first dose, there is sort of an average drop of 0.5 gram per deciliter, but a larger drop can occur. And thus we really keep these patients at a higher transfusion threshold during cycle 1, often closer to 8.5 or 9 grams per deciliter. But you could see after the end of cycle 1 and over time that actually hemoglobin significantly improved, and this is really correlating with response. And briefly just looking at efficacy data, this is focused on the high-risk MDS patient population. Again, an overall response rate of 73% with a true complete remission of 42%. And by waterfall plot, nearly all patients having significant bone marrow blast reduction. Again, overall, other than anemia, really no significant other toxicity, no immune-related adverse events. And this therapy has breakthrough designation with a phase 3 frontline trial being launched in MDS already. And then although I couldn't get specifically into the p53 mutant AML data, there will be a presentation by us at ASH which will focus on this group, and there is a phase 3 planned in 2021 for that group as well. And really last, just like to briefly focus on venetoclax, and although there is frontline data to discuss, what to do in this sort of HMA refractory patients, it's really a group that has really no standard of care therapy and really quite dismal overall survival. So this looks at venetoclax with azacitidine in the relapse refractory space. I think based on a lot of work, ultimately venetoclax in MDS is dosed on days 1 to 14, so different than the AML schedule. And so just briefly, I think we can see responses, and these responses, although the true complete remission rate is on the low end of about 7%, there's a high degree of patients that can get hematologic improvement, transfusion independence. Additionally, significant percentage of patients get marrow remissions, and then often these are not marrow remissions alone, but with some degree of hematologic improvement. And although the median overall survival typically in this group of patients can be 6 months or less, the median overall survival presented by Zidane at ASH of last year was 12.6 months. I think longer follow-up is needed, but again, potentially an option if there's not a clinical trial and they have failed a standard hypomethylating agent. And really with that, I think really like to highlight that I think the future is bright, that we may have multiple novel HMA-based combinations approved, and I think we really have to think how to best develop these. Is it triplet strategies? Is it sequence therapies? Can MRD guide us? I think really critical questions, but sort of an exciting landscape for us to look forward to. I thank you for listening to my part of the talk today.
Thank you, David. It was a really quite clear talk. We do have a case. This is a 64-year-old woman who had anemia and hypercellular marrow with dysplasia and increased blasts and poor risk cytogenetics with a p53 mutation. Whew, she's high-risk MDS. What do you do with her?
Yeah, so I think the biggest thing to emphasize is, if at all possible, this patient needs to go on clinical trials. So really the outcomes with standard HMA And again, not to overlap into the AML setting, but even HMA venetoclax, which we have, the outcomes are poor, and you're talking median overall survivals in the 6 to 9 month range. So I think clinical trial is most critical. I think all of the agents we discussed have shown activity in p53. Of course, we talked about p53 specific agent of eprinetapopt, but lots of data growing in Mcgrolomab and pevonedistat, sort of minimal data, although there is some data at EHA again where it appears some p53 patients are responding. So I think really it's just to emphasize for this group in particular, we really need to think about novel therapies as we're just not good enough with the standard of care.
David, what's your experience with some of your patients either on 246 or Pivo or Mcgrolomab who had these really amazing responses in the p53 population and then who subsequently got allo stem cell transplant? How are their remissions holding after transplant?
Yeah, I think it's a great question. So I would say there has been a trend for better outcomes, post-transplant. A lot of these analyses are ongoing. Median overall survival was in the sort of 15-month range, 14 to 15-month range, at least in our eprinetapopt trial. I think in these other agents, there's actually really quite limited data. But I think when we think about p53, really thinking about sort of a paradigm of total care. So trying to get their best depth of remission for the patients that are transplanted. I think we need to consider it, but we need to think about maintenance and very out-of-the-box treatments because I think, unfortunately, and I think we're still learning the biology of why their graft versus leukemic effect is so impaired with this group of patients that, again, if you're doing standard, I think relapse is still going to be a significant issue in this group of patients, even in the setting of novel therapy, but maybe maintenance, and again, with some of these different combinations can further improve how these patients do.
Right, so particularly if patients are getting a reduced intensity transplant, it's so important for the patients to understand that although we always say the transplant is the, quote, only curative option, close quotes, we don't really know necessarily what the expectation is for patients getting transplant. We're hopeful.
And I think with some of these therapies, I mean, you could make an argument, is it better to stay on these therapies and not go to transplant? I think really trying to identify which group of patients can benefit, what's their transplant, what's their conditioning, what's the maintenance, potentially look at. I think we really need to be thinking quite in depth for this molecular subset.
I think I remember at ASH 10 years ago, the debate counterpoint on whether auto is still, transplant is still recommended in myeloma with all the new drugs. And that debate continues, but here we are now in MDS, maybe not quite there yet, but approaching a point where we might be having a similar point and counterpoint, and that's exciting.
It's not necessarily because the new drugs are so much better. It's the transplant was never that great in this population to begin with either. Well, or maybe it's both.
I think it's probably a little bit of both.
Yeah. I'd like to spend a few minutes updating you on the National MDS study. I was formerly a co-chair of this study. Since I'm in the government, I remain on the steering committee. It's chaired by Mikhail Sekharis and co-chaired by Amy Discern from Johns Hopkins. And this is sponsored by the National Heart, Lung, and Blood Institute, along with support from the NCI. This is creating a multi-institutional longitudinal biorepository with samples from participants with either MDS or ICUS. The samples are all processed centrally, and the clinical data is procured to support future studies that will have high impact for MDS patients. I bring this to your attention because we'll still take centers, and if you're an NCORE center associated with any of the cooperative groups, you can open the study, and you do get credit for it. It's pretty easy. And patients are assessed by central pathology at Moffitt, actually. And if they don't have MDS or MDS-associated AML originally or ICUS, they don't give any further samples. But if they do, they're entered into a longitudinal cohort. And all they have to do is give blood every 6 months and fill out a questionnaire. But if you're going to do a clinically indicated bone marrow, we ask for more material so we can study it longitudinally. So it's pretty low wear and tear on the patient. And I'd just like to point out that you can see the variety of MDS patients who are in the longitudinal cohort, as you might expect. We have some patients with MDS-MPN overlap syndrome, ICUS as we expected, and some lower blast lower blast AML. Now, originally, those are the only patients we were keeping on the longitudinal cohort, and it was a very small percentage of the starting population. But we know that a lot of our investigators are really great hematologists, so we wondered why were so many patients being thought to be at risk for MDS and then being thrown out. Well, it turns out, as we started doing molecular analysis, that most of them had CCUS. And so we amended the protocol to include longitudinal follow-up of the so-called at-risk population. And you can see that this includes patients who have cytopenias and dysplasia, cytopenias and karyotypic abnormalities, cytopenias and NGS abnormalities, etc. So many of these are, in fact, the CCUS population. It's quite a big population, quite a big proportion of the patients who were thought by their doctors to have MDS. As we heard before from our previous speakers, if it walks like a duck and it quacks like a duck, even if it doesn't look pathology like a duck, it may still be a duck. So this is a very important study to see what happens to these patients longitudinally, biologically, and to look at the impact of the therapies that you choose on these patients. So I really encourage you all, we have a lot more accruals to go, to open up the study and contribute to the science. All the patients need to have is suspected MDS or overlap syndrome. They're getting a bone marrow anyway for diagnosis, and you can read about it, and you can do clinically whatever you want for them. But as I mentioned, they get central pathology review, and if they have MDS, overlap, low blast AML, ICUS, or now these other CCUS, etc., they're followed longitudinally. And that's all I wanted to say. We do have some posters here at ASH. I think that's actually an oral presentation that we've developed out of this already of a genetic signature that can help pathologists classify and avoid misclassification of MDS. So I bring that to your attention. So this kind of brings us to the end of our journey this morning. You've heard a lot about high-risk MDS. Importantly, I think we've gotten a lot of clarification on the very confusing area of clonal hematopoiesis. I think they do have clinical ramifications, and I think we need to pay attention to them. And we've heard that stem cell transplant is still the, quote, only curative option. I've shown my skepticism about it. We didn't talk about transplant, but we need to make it better. I'd like to thank again our co-producers, the Aplastic Anemia and MDS International Foundation, or AAMDS, a really wonderful foundation that I hope you are all very familiar with. They help investigators as well as practitioners and patients. And as you can see, if you're not familiar, they have wonderful resources, patient educational booklets, fact sheets, webinars, research updates, peer support networks, support groups, as well as patient management tools, my healthcare team, medical appointment trackers, symptom trackers, and blood transfusion records, as well as lots and lots of patient ed materials. David, we have a question from the audience. Question concerns a 72-year-old gentleman with MDS, intermediate 2 risk, well, probably nowadays he would be an IPSS-R high risk, let's say, since we don't use the IPSS anymore, and who responded briefly to 5-azacitidine. Should this patient go on a clinical trial, or should he go straight to haploidentical transplant? At this point, he's still got about 10% blasts in the bone marrow.
Yeah, so I like how you chose, the controversial, cutoff. I mean, I think historical, if bone marrow blasts are less than 5 or less than 10 based on some guidelines, that you can take these patients to transplant. Of course, at 72, this is more of a reduced intensity type transplant. And I think, your challenge is, we know from the WashU group that, this group clearly has higher rates of relapse. And I think the challenge is until now, we really didn't have anything. So I think this group is prime for clinical trial. For me, if a patient is not eligible for a trial or just can't go on one and their blasts are, let's say, pushing into that 10%, I do regularly add venetoclax with all the qualifications of not clear data and sort of off-label in that usage. We have published a recent paper in Blood Advances with the Sloan Kettering group where that patient group did appear to do well sort of with blast clearance into transplant. And I think importantly, what I'd really like to look at is sort of deep sequencing And potentially, if we can clear patients, pre-transplant, I think that's going to lead to better transplant outcomes, but we have to prove that. And so my hope is in the setting of some of these novel combination therapies that we can achieve that, and that may be a critical metric.
Thank you for your attention. We thank PeerView Live for their support, and we wish you a really wonderful ASH, and please do your social distancing and wear your masks, and please stay safe.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/ZAW860. This activity is supported through educational grants from Agios Pharmaceuticals Incorporated, Astex Pharmaceuticals Incorporated, Bristol Myers Squibb, Taiho Oncology Incorporated, and Takeda Oncology. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education.